Now it's Sonja Bass, who works at Postpartum, to talk about the DIC.
A postpartum hemorrhage was the primary event, and DIC was secondary to a possible amniotic fluid embolism versus severe hemorrhage. Amniotic fluid embolism can also be referred to as an anaphylactoid embolic syndrome. So the syndrome occurs when amniotic fluid and various other debris products, such as vernix, mucus, squamous cells, enter the maternal circulation, causing cardiopulmonary or cerebral emboli. The coagulopathy involved includes widespread activation of both coagulation and fibrolytic processes. So disseminated intravascular coagulation, which I will refer to as DIC, the definition itself is an acquired secondary complication resulting in widespread formation of clots in the microcirculation. It's initiated by generalized overactivation of the coagulation process, and it is characterized by the depletion of large amounts of fibrinogen, platelets, prothrombin, and clotting factors. Now, for the sake of our students and our audience, it's important to understand it's important for me to touch on hemostasis with regard to the pathophysiology of DIC, so I'll do that briefly. So in order to understand the patho of DIC, it's important to be familiar with normal clotting processes of hemostasis. So the primary hemostasis ends with the formation of a platelet plug or platelet adhesion. Secondary hemostasis begins with the activation of the clotting cascades, the intrinsic, which is response to the blood vessel damage or the collagen release, and or the extrinsic, which is in relation to tissue damage or the release of the thromboplastin. And it ends with a common pathway activation, which results in a sturdy fibrin clot. So once the clot is formed, a simultaneous process of clot lysis and breakdown must occur for normal circulation to be reestablished. Clot lysis requires consumption of clotting factors. Therefore, if lysis takes place too rapidly, as may be the case with profound hemorrhage, bleeding may be perpetuated. So now I'll talk about the pathophysiology of DIC. So DIC occurs when the consumption of the clotting factors exceeds the liver's ability to produce the factors. The depletion of the factors results in bleeding. The body continues to try to form clots in the presence of bleeding, further depleting the clotting factors. Ultimately, a cycle of pathology begins in response to the widespread overstimulation of the coagulation and fibrinolytic processes. So the consequences of DIC, of course, hemorrhage, resulting from platelet consumption and depleting of the clotting factors. Increased tissue hypoxia and ischemic necrosis that results from obstruction in the microvasculature by fibrin plugs. In the presence of ischemic or necrotic tissues, such as seen with retained products of conception, tissue thromboplastic material may be released into the maternal circulation, activating the clotting cascades, causing the depletion of the clotting factors. And then hemolysis, which results from the destruction of the erythrocytes within the microvasculature. So I'm going to touch on the laboratory findings of DIC and how they correlate to Mrs. P. So we did see her lab values, and I'll try to correlate the two. So decreased platelets, less than 100,000. If you'll recall, on 12/21, Mrs. P's were at 128,000. On the 22nd, they were 44. On the 23rd, they were 15. And at discharge, they were 237. So decreased fibrinogen, less than 400. On 12/22, hers were less than 60. Post-cryo administration, they came up to 208, and they remained fairly consistent. And then at discharge, they were actually over 400. So increased fibrin degradation products would be greater, in DIC, it would be greater than 10. So, and this is actually determined through the D-dimer test, which is considered the most reliable test for DIC. It assesses for the thrombin and the plasmin activity. In her case, they were greater than 20. So any elevation in the value would be considered abnormal because normal plasma does not have detectable amounts of D-dimer of fragment D dimer within the circulation. So prothrombin and partial thromboplastin time, the PT and the PTT may be altered during DIC, but the values are not always as helpful as the platelet and the fibrinogen levels in determining the severity on a continuum. The platelet and fibrinogen lab values are considered most useful in evaluating the effectiveness of therapy. So the prolonged PT and PTT are late signs of DIC, and because 50% or more of the platelets must be consumed before the lab values would be abnormal. So with regard to DIC management, the primary therapy for DIC is to correct the underlying cause. In her case, it was actually hysterectomy to stop the hemorrhage. So simultaneously to treating the underlying cause, aggressive fluid volume, blood, platelet, and clotting factor replacement is and was initiated to manage the hypovolemia as well as the coagulation defects. Physiologic function should be and was supported via continued vital, renal, organ function assessments, LOC assessments, along with O2 supplementation. So more invasive hemodynamic monitoring may be and was indicated for Mrs. P to accurately assess the intravascular volume, the cardiac output, and the O2 transport status. In her case, she went to the intensive care for further assessment as well as care. However, her husband, Mr. P, came to our unit postpartum, which I wasn't working on the night of the event, but I wasn't working the nights to follow. He came to the room and stayed in the room and cared for the baby, which was a beautiful thing. So as far as patient outcome is concerned, she was discharged on January 11th in stable condition, and if you'll recall, she was admitted on December 21st. And at this time, patient has no memory of the delivery or the events to follow.
What were the drugs that she got after delivery? She got Pitocin, she got Cytotec, she got Methergin, and she got Hemabate. The question was, is Methergin indicated? Methergin is always indicated. If they have hypertension before they're delivered, if they're bleeding that bad, they're already hypotensive. So Methergin is a consideration.
We implemented several changes in labor and delivery to increase patient safety. Policies we've changed. It used to be that all type and screen were just done on low-risk patients and multigravida. Now, type and screen are now ordered on all admissions regardless of gravidity and parity. We have collaborated with our blood bank regarding timing, type and amount of blood products available in emergencies. We also had educated staff availability of blood. There is a blood transfusion postpartum hemorrhage protocol in blood bank for massive transfusion. We had created a postpartum hemorrhage trained labor and delivery for emergencies. We used to go to the operating and run to get our supplies, and the perinatal team is in the process of reviewing the OBERT. It's the OB Emergency Response Team order sets in Connect Care.
We added the hemorrhage medication kit to the Pyxis so that we could have all the drugs together at one time. And most recently, we had that added to the mother-baby Pyxis as well. And we created a postpartum hemorrhage cart, which I'm going to show you. This cart is kept in labor and delivery, but we bring it to mother-baby when they need it. And this has everything that we might need, minus the blood, if we have a hemorrhage. It's kept locked because we have syringes in it and needles. So in the top drawer, we have supplies to start an IV. We have needles. We have the filtered needles since Methergin comes in a glass vial, IV start kit, and tape, and normal saline flushes. In the second drawer, we have suture if the physician needs to sew up a laceration, which is what's causing the hemorrhage, they have suture available to them. We have O2 tubings and mask. All of the labor and delivery rooms have these available for our patients at the bedside, but they're not over on mother-baby, so we keep them in there for the mother-baby nurses. We have sterile gloves, sterile towels. We have a jetty balloon, which I have one out of the package here. This is It's actually a vaginal balloon. We put about 300 cc's in this. If the physician is having trouble visualizing the episiotomy or laceration repair, we'll put this in there to keep the blood from coming back out of the uterus and clouding their field, so they can have a clearer field. So that's in that drawer. We have normal saline and LR and all of our blood tubing and regular IV tubing. We have the blood warmer tubing, and we have pressure bags in this drawer. The bottom drawer has our Ebb balloon. We have a Foley catheter kit, a straight cath kit, a weighted speculum, a regular speculum, and if they want to try to do a DNC, a mini DNC, we have a curette and a sponge tick for that. And I have an Ebb balloon that is out of the package, so you guys can see. This is the balloon that actually goes up in the vagina into the uterus. So the physician will flatten this out, put it in the uterus, and we will attach the bag of normal saline and fill it. And it does fill rather quickly because the tubing is so fat. And then if they want to fill the vaginal balloon, we have a separate port for that. And you can actually clamp them together so that they're clamping on the cervix. This port we can actually use to put a Foley bag, just the bag too, and we can monitor how much blood loss is coming out from that. Right, you're right, we did not have that. This is relatively new. So that's that. In our little reference book up here is our chart with all of the pads and how much they weigh dry. And we also have the postpartum hemorrhage protocol in here, as well as the drugs for reference and the policy for giving blood. And we also have a tracking tool that we can use so that we can review what's done and see if there's anything that needed to be different or what we can do better. And I also wanted to show you guys, just for fun. All right, the postpartum girls in here are not allowed to answer this question. And nobody can look and see how much this is. Just to give you an idea, these are the pads that we put under our patients. So, anybody have any idea how much that might be? Since if they cheated. 250? Anybody else have a guess? That's 500. And so, I mean, you can kind of, that's a hemorrhage. If you've pulled that out underneath your patient after a vaginal delivery, that's considered a hemorrhage. And it's really, it doesn't really look all like, that much. In fact, some of the doctors that I showed this to actually estimated it to be about 300. So, that's why we weigh.
Other than anesthesiology, is there, in a hemorrhage case, anything else that you guys use to help control blood pressure to keep it down in a hemorrhage case?
Keep the blood pressure down?
Yeah, you want the blood pressure low?
Well, if they're bleeding out, I guess the question is, what do we do to keep the blood pressure? If they have hemorrhage, their blood pressure is, like this case, when we got her to the OR and got her on the OR table, we couldn't even palpate her blood pressure. Yeah.
What was the outcome for the baby?
The baby did well. The outcome for the baby was it went right to the nursery, and it stayed in our nursery for a while because mom was in ICU, but the family did visit. And she had older children. Her children were old enough that they came and they helped take care. The dad was a little, he wasn't used to babies. We had to teach him over again what to do. But he did well, and the baby was fine.
So no ill effects?
No, not at all. It's because the issue happened after the birth.
What does your policy say about venous access during and after labor? Like, how long do you have to maintain an IV, or does it say?
What's our postpartum policy? They keep a heparin lock. They keep a saline lock.
Why did? Because I noticed that that this patient did not have an IV when she started bleeding because they.
She did.
Did it blow? Because
well, they were trying to. Right, they're trying to put additional lines in.
Okay.
Yeah, and they put 2 IJs in her.
And what was the initiative, I guess, to make all these changes? Was
this case?
Mm-hmm. So was there something at the time, because the way it's presented, it sounds like that really nothing else that you all at that time could have done. She delivered, she immediately started bleeding, the kit was given, and it just, everything went. So at the time that this patient had this situation, all that could have been done was done. Well, but what was it, just reflective thinking that, well, we don't have this or we don't have this?
Right, that this case ended up well, and we had an excellent physician in-house at the time when this happened. But when it happens when the physician is not in the room is kind of what generated our thoughts as to what we can do for us.
Did her make it to postpartum, or she was still back in labor and delivery, right?
Right, she started bleeding immediately after delivery and went right to the OR and then right to ICU.
So in essence, we're taking proactive measures to ensure quality care and safety of our patients.